today we are going to be discussing on a very important subject of male fertility, or shall we say infertility, and are we reducing the male to only a sample? Let's see what we can do about this particular topic, because this has bugged the infertility population more and more because we know less and less. So, let us go to the subject without much of ado and see what we can do. The future of male fertility, are they reduced to a sample in art, is a question I am asking all of you. Infertility affects an estimated 15% of couples globally. Males are found to be solely responsible for 20 to 30% of infertility cases and contribute to almost half of the cases overall. For quite some time, sperms have been considered mere vectors that carry the paternal genetic component to the oocyte. So, the sperm evaluation was limited to sperm conventional semen analysis. Many genetic advanced paternal age and lifestyle factors have been implicated in male infertility. However, about 30% of cases are idiopathic. Paternal factors of genetic origin such as sperm structure, abnormalities, sperm DNA fragmentation, epigenetic defects in the sperm aneuploidies and Y chromosome microdeletions affect the embryo quality in art. Look at this complex slide. All it tells us is the genome of the paternal sperm. The paternal genetic factors will show you that on all these things it is only telling us about the aneuploidies, the DNA fragmentations, and of course the epigenetic factors. And if we go into the Y chromosome, we also know that there will be on this Y chromosome an azoospermic factor. So, if we have to look at the paternal genetic factors and embryo quality, I want you to concentrate on this slide a little bit more, because we will look into the details of that Y chromosome. On the left hand side, we see the stage, which is A, B and C. So, fertilization at the zygote stage and at the cleavage stage. And if you look down from the stage, you look at the defect, the effect and the stage, that is D, E and F. So, let us just look at the stage A and look at fertilization. What could be the defect at the time of fertilization? And that is decondensed chromatin. What could be the effect? Decreased fertilization capacity. Now, at the zygote level, what could be the defect? Immature chromatin, altered P1 P2 ratio, and of course, the AZFC microdeletions. And the effect would be decreased fertilization rate. And the 4-cell stage, that is the cleavage stage embryo, again the effect and defect would be altered P1 P2 ratio, DNA strand breaks, sperm centrosomal defects, and the effect would be arrest at 2 to 6 cell stage embryo, lower cleavage rates, abnormal spindle formation. Let us look at the next set of stages that would affect the embryo: the morula, the blastocyst and the fetus. So, what is the defect at the morula stage? Immature chromatin, increased levels of histones, AZFC microdeletions, and that would cause an altered cleavage rate. At the blastocyst stage, you will have immature chromatin, altered P1 P2 ratio, skewed histones, protamine ratio, AZC fraction, microdeletions and DNA fragmentation. What would that lead to? Would be poor embryo development, decreased blastocyst rate and poor embryo quality. Now, coming to the fetus stage, the sperm aneuploidy, altered P1 P2 ratios, hypermethylation of sperm DNA, DNA fragmentation, AZFC microdeletions. That leads to aneuploid embryos, higher number of grade 3 embryos, implantation failure and pregnancy failures. So, the sperm has an effect at every stage of the embryo. What is the use of blaming only the woman when the man also has so much of an effect on the embryo? So, my dear friends, when you go back to your labs, please look at this right from the stage of fertilization to the fetus. You could have a male component for defect and effect. So, my dear viewers, when you go back to the lab, go back with the mindset that it could be a sperm problem or an egg problem when you have problems with the embryo in the lab. Here we have the sperm chromatin damage, a single strand break, a damaged base, a mismatch, a double strand break, an intra-strand break and cross-link, and inter-strand cross-link. So, we have a whole lot of mix and match where things can go wrong in the genome sequence of the sperm. So, therefore, they are very liable to a lot of genetic abnormalities. So, even if you have a 4% normal forms in the sperms, it is considered to be normal because there is a high chance of abnormal sperms. But there is a natural selection process where we do not have that number of abnormal babies. Let us look at the sperm chromatin damage, the biological mechanisms. The protemination failure, that is deficient replacement of histones to protamines during spermiogenesis, oxidative stress, epididymis transport and post ejaculation, where in a semen analysis you see a lot of leukocytes or immature sperm, low levels of semen antioxidants. The third is the apoptosis, which is cell death or programmed cell death during sperm maturation, the testes and the epididymis, and things can go wrong. And this is very important for us to understand that if you go through this process, let us look at it one by one. Here we have the sperm DNA fragmentation, that is both the intrinsic factors and the extrinsic factors. The intrinsic factors are abortive apoptosis, defective maturation, a vulnerable sperm which is exposed to these kind of intrinsic factors, as a result of which the head of the sperm tends to get cracked. As a result of these cracks, you are not able to see that in an analysis. For that, you need to have a very powerful microscope to see these cracked DNA in the head. So, the sperm DNA fragmentation would give you a very high count of sperms or even the kind of quality of sperms or motility, but when you actually look at morphology, the DNA fragmentation index of above 30% will tell you that these sperms are incapable of fertilization. So, sperm DNA fragmentation is something that we must look for when we look at sperms with a lot of debris, and this means infertility, impaired reproductive outcomes after IUI, IVF and ICSI, increased risk for genetic and birth defects. After seeing the intrinsic factors, let us look at the extrinsic factors, primary pathologies of male reproductive system, and what can that be? It could be immature or abnormal sperms, prolonged stasis during the epididymal transit and a varicocele. Now, what could that oxidative stress be? Because everything is now dumped on oxidative stress. Now, that oxidative stress could be due to drugs, smoking, pollution, radiation, any systemic infections, even high fevers, diabetes and cancer. So, environmental and lifestyle factors play a very important role in this sperm fertility. Systemic pathologies also play an important role. Now, when you look at the types of the DNA damage in the sperms, it is DNA fragmentation, or it can go even further down to look at the mitochondrial DNA damage. And what happens as a result of this, the length of that sperm as a result of that chromosome being shortened. So, we call that as a telomere attrition. And then the epigenetic abnormalities is the environmental effect, and if you look at the Y chromosome here, you will see the AZF fragment, and this AZ fragment has 3 parts, A, B and C. And what happens to this Y chromosome deletions? You will find that when you have these deletions, the chance of this being passed on to the baby is very high, particularly for a male. So, we have to really counsel the mother that this could happen. So, then they have a choice whether to go for a donor gamete or to still go for a child of their own genetic material. Now, this is a very complex slide. The next slide would be the epigenetic reprogramming during spermatogenesis and male factor infertility. Now, what do we do here? We have a mitosis, a meiosis and post-meiotic differentiation. So, we start at the primordial germ cell, and of course, with all the histone tail modifications and transcription of RNA molecules. And as a result of all this, from the primordial germ cell to the spermatogonia, the primary spermatocyte, secondary spermatocyte, the round spermatid, elongated spermatid and then the spermatozoon. As a result of the primordial germ cell, we find that the demethylation and the de novo DNA methylation, things can go wrong over there. But if you look at the entire thing, the environmental toxins like even paints and hydrocarbons, pesticides have a spermatogenesis impairing effect. Diet and smoking, sperm cryopreservation and even estrogen receptor agonists have an effect on the sperm fertility. Factors that are associated with impaired reprogramming and aberrant genome modifications that may affect the fertility and health of the offspring actually starts at the methylation process. Sperm DNA integrity testing. What is the background? The normal sperm chromatin essential for paternal gene transmission, the sperm DNA damage which results in infertility, recurrent pregnancy loss, poor outcomes in IUI and IVF. What could the principle be here? Quantification of sperm DNA strand breaks, and the specimen used in these cases would be the semen. The techniques here are nuclear dyes, direct assessment using the tunnel or the Comet assay and the nuclear matrix assay, which is the SCD. Sperm DNA integrity testing and art. If you look at this on the left hand side, you will see that where the DFI, that is the DNA fragmentation index, is above 30%, the live birth rate is very low. And if you look at ICSI, even though the ICSI levels are higher, it is only because you select the sperms without the fragmentation because of the higher microscope power that you use, and you will see that the chances of pregnancy with an ICSI is much higher than with an IUI. Sperm DNA fragmentation is associated with pregnancy loss and negatively impacts ART pregnancy outcomes. And this level of evidence is 1 and 2. Although viable pregnancies can be obtained, STF impacts early fertility checkpoints. One is at fertilization, embryo development and implantation. So, we need to look at that level before we actually diagnose why did this lady miscarry. The ESHRE guidelines on recurrent pregnancy loss suggests that the sperm DNA damage, the association is moderate and probably, but no prospective studies to confirm, and the prognosis is unclear and treatment has not yet been suggested. The only thing that you can do is to do ICSI in these cases or use testicular sperms for this particular case. If you have interventions for high sperm DNA fragmentation, then look at this colorful slide. Sperm DNA fragmentation testing, which has abnormal results. We have 4 ways of looking at it. Avoid factors that promote oxidative stress, and then that is smoking and obesity, then try and quit smoking, reduce weight. The oral antioxidant intake like vitamin C, E, folic acid, selenium, zinc and carnitine. The other thing is of course to look at treatment of underlying pathology like a varicocele repair of grade 3 and 4, genital tract infections and leucospermias, and of course a short ejaculatory abstinence and testicular sperms. Of course, if all these things just do not work, then go in for ART with an ICSI and then a sperm selection techniques like IMSI, and then you will be able to get a baby of your own genetic origin. Look at this particular picture where you see the graph on your right hand side, and intervention improves assisted conception, cytoplasmic sperm injection outcomes for patients with high levels of sperm DNA fragmentation, which is a retrospective analysis. If one does a testicular sperm ICSI, you have a pregnancy rate rising from almost a quarter to almost half, which means 24% to 43.7%. And this only happens because you are able to select the right sperm with the microscope and also make sure that this is the only sperm that actually fertilizes the egg. So, the chances that you may have an euploid embryo, and that selection of that particular embryo by looking at it through the embryoscope will further select that embryo to be able to give you a viable birth. And therefore, today, while you can do a whole lot of other things medically by giving antioxidants, so therefore, when you see that the pregnancy rates jump up right up to 50%, it only means that you are selecting the right kind of sperm to fertilize the egg. Thereby, the selection process is very, very strict, and you are able to look at a viable pregnancy purely because you have taken the right sperm. This not only helps us to get a viable pregnancy, but also to have the genetic makeup of the couple. This is extremely important because if you have a lot of the leukocytes in the semen, we find that it becomes very, very difficult, and this can result in recurrent pregnancy loss and can become a very frustrating experience for the couple. So, let us look at this slide, a comparison of reproductive outcome in oligospermic men with high sperm DNA fragmentation undergoing intracytoplasmic sperm injection with ejaculated and testicular sperm. The conclusions have been that where you have used ejaculated sperm, the pregnancy rates are slightly lower than if you use testicular sperms. Why is it so? It's only because when you use ejaculated sperms, you are taking the sperms from the semen which has the ROS. Whereas, if you take the testicular sperms have not had time enough to mix with the semen, and therefore, this is devoid of ROS, and therefore, the pregnancy rates are much better and the DNA fragmentation rates with testicular sperms are much lower. This table here of clinical pregnancy, miscarriage and live birth rates in testicular ICSI and ejaculated ICSI cohorts will suggest that if you want to treat with testicular sperms and ejaculated sperms and make a difference, you will need to do 5 testicular sperm injections to 1 ejaculated sperm to show the difference that testicular sperms where the DNA fragmentation is high will give you better pregnancy rates than if you were to do with ejaculated sperms alone. The reproductive outcomes of testicular versus ejaculated sperm for intracytoplasmic sperm injection among men with high levels of DNA fragmentation in semen. It's a systematic review and analysis, and again here it shows that the testicular sperms are much better than the ejaculated sperms. For the reasons I have just given to you is that the ROS fraction is much lower, and therefore you will be able to get a better impact of these sperms which have not been exposed to the reactive oxygen species. When to test for sperm DNA fragmentation? If you look at this, we could do it for unexplained infertility, recurrent pregnancy loss, IUI failure and IVF failure. And if we have to see where there is a high SDF, the sperm DNA fragmentation, let us look for presentable, correctable conditions associated with SDF like a varicocele, lifestyle modifications as well as genital infections. And if there is no infections or any of the other conditions, then you can go in for an ICSI straight, and then the other side, if there is infections, then treat the underlying infections, and then we will go for the high SDF. And in high SDF again you can go for ICSI. However, if at that point of time, if you have an ICSI failure, then perhaps one would have to look at extracting testicular sperms to get the fertilization, and this would be the algorithm that I would be looking for if you have a very high SDF. So, if you look at the next slide, it would suggest to you that the SARS-CoV-2 infection and sperm DNA fragmentation. Does the SARS-CoV-2 infection cause sperm DNA fragmentation? Possible link with oxidative stress? Well, we will have to look at this complex slide over here and say that, well, the anterior pituitary luteinizing hormone as well as the Leydig cell testosterone with a little bit of inflammation acts on the epididymis as a result of orchitis, that is infection of the testes, and psychological stress, and this is the one thing that leads to oxidative stress with a low TLH ratio, and as a result of comorbidities and age factors we have high DNA fragmentation. So, this definitely does affect. So, SARS-CoV infections are a cause of sperm DNA fragmentation. The next slide that we are going to look at is sperm aneuploidy. That with sperm aneuploidy, males with abnormal karyotypes and subgroups of fertile and infertile males with normal karyotypes may be at risk of producing unbalanced or aneuploid spermatozoa. Biological, clinical, environmental and other factors may also cause additional sperm aneuploidy. Increased risk of sperm aneuploidy is directly related to chromosomally abnormal embryo production and hence to poor reproductive potential. And how do we test for sperm aneuploidy test? The SAT is a test to study the genetic factor of male infertility. This test evaluates the percentage of spermatozoa with chromosomal abnormalities in a sperm sample. Analysis is performed on the chromosomes most frequently associated with spontaneous miscarriages and children with chromosomal abnormalities of chromosomes 13, 18, 21, X and Y. So, if we have to then look at what could be the percentages of men with abnormal sperm abnormalities, well, percentages here look at approximately 13.5 that is 13.8% would really have repetitive implantation failure. You will have recurrent miscarriages with 11% and mixed causes, of course, with the others, like for 12.7% with mixed causes and a male factor, a huge male factor of about almost 18%. And this is something, this is an eye opener today. And we should also look at why should we use sperm aneuploidy test. If we do a sperm aneuploidy test, then we know which are the sperms that actually has aneuploidy. Now, we know that every sperm has 23 chromosomes, and this is because the gametes are haploid. And when you want to test these chromosomes, if these chromosomes in the sperm are more than 23, you know that it is aneuploid. So, let us look at the increase in pregnancy rate if you do the aneuploidy, because you will throw out the abnormal sperms. It also decreases your miscarriage rate, and SAT helps to provide personalized genetic guidance to the couple before IVF treatment. In couples with an abnormal SAT, it is clearly advisable to perform a PGT-A, and that is important for us to select chromosomally normal embryos for transfer, and this is extremely important for us that today we do not do something without having an anomaly test. Now, if you look at this slide, which is quite pictorial, it only suggests how do you do this. Here we have a semen sample on the first slide, this thing with the test tube. The second is to wash it with culture media. Then you have the Conray solution. The fourth will be that the sperm spreads, then decondenses sperm nuclei and the heads. Then there is hybridization in the sixth, and of course the detection, and then you go to the microscope to analyze this report. Now, are we looking at, after doing this, we are now increasingly looking at, are older men at risks for abnormal babies? Hitherto, we had thought that it was only women that were responsible, that as soon as the woman crossed the age of 35, they start testing for chromosomal abnormalities like Down's syndrome and all the other aneuploidies. But today, we know that even advanced age for men also has a risk, and therefore, we have to look at this factor as well. While the change in fertility is more drastic in women, men have biological clocks too. So, advanced paternal age has abnormal semen parameters and also an increased risk to genetic sperm defects. So, what could be the defects? The genetic sperm defects here decreases fertility, increased chance of miscarriage, increased risk of birth defects like Down syndrome, congenital heart disease, achondroplasia, cognitive disorders, and such as the autism. Now, why is this important? See, many times when you look at these syndromes, Down syndrome cannot actually 100% be diagnosed only by ultrasound. And of course, autism, even after birth, many a time it is only as the child starts growing that this autism can be picked up. So, it is important for us to pick this up much early at the gamete stage rather than to go at the pregnancy stage and do prenatal diagnosis, because it would be too late. And of course, we also have an increased risk of childbirth. Now, where is the male aging? Did we think that the males do not age and it is always the women that age? My dear friends, we are wrong. Let us look at the semen parameters. The semen production is decreased, motility is decreased, vitality is decreased, volume is decreased, and normal morphology. The hormonal alterations also, there is a decrease in the testosterone and an increase in the FSH, almost tantamount to a male or an andropause, like a menopause. Then of course, the fecundity problems, the time to pregnancy, abortion rates increase and pregnancy rates decrease. What could be the testicular alterations? Testicular volume as well as testicular vascularization, testicular epithelium, and Sertoli and Leydig cell mass. And of course, let us not forget that the sperm DNA fragmentation also increases. So, the impact of paternal age on embryology and pregnancy outcomes in the setting of an euploid single embryo transfer with ejaculated sperm is a retrospective study. It shows that advancing paternal age has a detrimental impact on rates of blastocyst formation and euploid status, which only goes to show that it is here to stay, that women age and men age. So, fertility drops as aging processes increase. And looking at this, advanced paternal age is associated with an increased risk of spontaneous miscarriage, which is a systematic review and a meta-analysis, and therefore, one has to look at whether we need to inform the father as well, that because he is aged, there could be abnormalities, because it is always blamed on the woman that it is her fault that the baby is abnormal. So, given that chance, a lot of these slides that I am going to show you, though it is busy and they are very small figures, if you see these small kind of diamonds that are there in the center, because it is on the right, it shows that age does have an effect on the pregnancy rates. And if you look at the diamonds again on the right, this also shows that definitely age has an important influence on the outcomes, which is detrimental. So, is advanced paternal age a health risk for the offspring? It is very important. Yes, it is also an risk for the offspring is because stillbirths also happen when this musculoskeletal syndromes, cleft lip, acute lymphoblastic leukemias and retinoblastomas are also known to occur when there is a paternal age which is higher at the time of conception. So, we need to now go into the very important factor of Y chromosome microdeletion. So, if we look at the Y chromosome microdeletion, the genetic defects such as mutations and chromosomal defects have been estimated to account for at least a third of male infertility. The Y chromosome harbors genes important for spermatogenesis on the distal portion of the euchromatin segment of the long arm and are arranged in azoospermia factor, that is the AZF region. The spermatogenic focus is divided into 4 subregions, that is the A to D, and the incidence of this happening in azoospermia cases is about a third to about fifth. Now, 7 to 10% of men with idiopathic severe oligospermia also exhibit a Y chromosome microdeletion. So, we need to look at this chromosome. You will see this Y chromosome, and the red portion there is the AZF fraction, and you will see that the A and the B and the C are there. You will find that when you have the C fraction, you will see the DAS part of it. These are all very important factors, that if you have any of these, the chances with the A's and the B's, there is no chance of conception, but with the C's there is a chance. But should there be a conception, the chance of a male offspring of this person is likely to carry the same gene. So, if it is a female, then the child escapes any genetic abnormality. As a male, this carries the same infertility into the next generation. So, we need to look at the Y microdeletion. What has been the background? It is only deletions linked to spermatogenic failure, and it is seen in severe oligospermic and the non-obstructive azoospermia patients. The principle here is that the PCR of the long arm of the Y chromosome and can be tested in peripheral blood, and the clinical significance here is that diagnosis and predictive value for sperm retrieval. There are many times we have seen that when the severe oligospermic male comes to us for treatment, there are n number of treatments that are given for years, for months, and they say you take this, whether it is Ayurveda or homeopathy, allopathy, Unani and what not. But when you have this kind of Y microdeletion, my dear friends, it does not help. There is no point in fighting with the genetic abnormality. So, when this happens, it is better for us to say, well, my dear friends, we will try if there is some sperms, but if you do not have any pregnancy, it is better to go either for a donor or for an adoption. So, the genetic causes of male infertility will be roughly around this particular area, that is about 5% with Klinefelters, Y microdeletions and congenital vas absence, which means about 20% is what we are looking at, and about 80% would be idiopathic. So, if you look at the deletions occurring in the AZFA, results in type 1 Sertoli cell only syndrome with no spermatogonia. Deletions in the AZFB results in spermatogenic arrest, usually at the spermatocyte stage, and deletions at the C stage are associated with type 2, and some spermatogonia are seen with limited spermatogenesis or hypospermatogenesis. Microdeletions restricted to the AZFD region may present with mild oligospermia or even normal sperm counts with abnormal sperm morphology. So, we will have to look at where does this microdeletion occur. And if you look at the microdeletions on this slide, if it is the AZFA deleted, or if there is a B deleted or a C deleted, you will see that in the A and the B you will not have any retrievable sperms, but in the C fragment you will be able to get approximately 70% chance of retrieving testicular sperms for ICSI. So, we need to understand where exactly is the deletion. That will help us to take it further in terms of fertility management. So, AZFC deletion and partial AZFB deletion are associated with sperm retrieval of over 50% of cases. Retrieved sperms are found to be fully fertile in both ICSI and IVF procedures. High risk transmission of this genetic disorder to the male offspring. Screening of infertile men prior to ICSI is necessary. Informed consent has to be obtained explaining the risk of transmission to the male offspring. So, we need to explain that certain Y microdeletions are associated with a progressive change from oligospermia to azoospermia. Preventive therapy like cryopreservation of sperms for successive assisted reproductive techniques could be proposed to affected sons. In conclusion, that it was traditionally thought that the sperm was only a vessel to deliver the paternal genome to the oocyte. Recent advances have shown that the function of sperm extends immeasurably beyond this. It is a great essence to understand how abnormalities at different levels of paternal genome organization may affect reproductive potential and outcome. With current and future effects, examining the molecular and genetic factors responsible for spermatogenesis and fertilization, we may be better able to understand etiologies of male factor infertility and thus improve outcomes for our patients. So, with these few words, I must tell you that we have not written the last word on male infertility. We need to understand that till we know what is it that is going to cause these kind of defects, and till we know that we can get 100% blastocyst transformation, we still have not conquered the Da Vinci Code of male fertility, or sorry, it must be male infertility. So, till that time we still have to understand that both male and female are equally responsible for infertility, and as long as we understand this and we go ahead and say, let us look at the problem with our eyes open and our brains open, so that we do not blame anyone, and infertility is more a fact finding rather a fault finding mechanism. And this, my friends, is a difficult road, but often leads to beautiful destinations with a lovely baby in the hand, and that is what I would like to see as far as male infertility is concerned. Thank you very much.